key thing that when you talk to any clinician, and for those of you who are going to be clinicians, you're going to find out when you get out into, the clinics and the hospitals in private practice, rashes do matter, okay? Not only where the rash is, but the appearance of the rash. Is it a bunch of little pustules, little small, little yellowish fluid-filled sacs? Is it flattened, reddish, dry skin? The rash where it is and what it looks like can be clinically indicative of not only what the disease is, but what's causing the disease. In this subsection of chapter 16.3, we're going to be looking at what are referred to as maculopapular rash diseases. Maculopapular. Oh, it's a mouthful. Maculopapular, okay? These are going to be rashes that are dry, reddish, flat for the most part, but there's going to be raised little pustule bumps throughout, okay? Specifically, the diseases that have this: measles, rubella, fifth, roseola. Thing to keep in mind here: measles, rubella, fifth disease, roseola. These are going to be infant, early childhood diseases. So age of the patient is also going to be something to take into account in the clinical setting when you're presented with a patient that has a rash. How old are they? Where is the rash? What does it look like? Characteristics of our first one: measles. You'll also see this referred to as rubeola. Measles is not something we see very often here in the US because we have an early childhood vaccination, an infancy vaccination. MMR is one of the first vaccinations that infants will see. Measles, mumps, rubella. We've had a vaccine since the early 60s, but we still see a few hundred children a day die from this. Who are we seeing die? Well, these are going to be some parents still do not get their children vaccinated. These are the anti-vaxxers. And, well, it turns out vaccines are not perfect, okay? Vaccines will work for the majority of the population, but not all. Why did we come up with a vaccine for measles? Well, you look at that third bullet there. 6 million people. Not just children, adults were dying from this too, but 6 million a year. That's a lot of people. So they figured out to come up with a vaccine. They do it as an early child in an infancy vaccine. We vaccinate, give a fighting chance to the infants, so they make it to adolescence, adolescence to childhood, to teenage years, to adulthood. So we limit the exposure early on, and then we limit transmission. It's a weird thing, as that last bullet shows. In the US and many of the developed countries, parents are now opting out, refusing to vaccinate children because they believe that whole vaccines cause autism thing. Never been proven, never been shown. The one minor paper that was published was retracted because the MD who wrote it falsified all of his data. But it still persists. Decade or so later, we still have people pulling this one out. What do you see from a clinician standpoint? Sore throat. Patient's going to be complaining of a sore throat. If it's an infant, they're going to not want to swallow, or you're going to see when they do go to swallow, they're going to make a face. Oh, it's painful. A dry cough. Dry cough, what does that mean? It means when they cough, they're not coughing up anything. Okay, normally when you cough, whether you know it or not, you're pulling sputum up out of your lungs, out of your throat, which you then swallow back down. Lymphadenitis. Basically, lymph nodes in given areas are going to be starting to swell up. Going to be fever. Some patients are going to develop what is referred to as Koplik spots. The rash actually will spread, as you see here, the rash, small raised areas. That's going to be all over the trunk, the chest, the abdomen, front, back, and the head. And that rash will then also spread into the mouth. The rash there, though, becomes secondarily infected because of the bacteria there, and you get these oral lesions occurring, what they refer to as Koplik spots. So notice there, that last bullet I just stated, the rash will be over the entire trunk and the head. Okay, that's the location. Other complications, laryngitis, bronchopneumonias, secondary infections, eye, ear, sinuses because of the rash, pneumonia, turns the rash. Also then, these spots not only go in the mouth, the sinuses, the eyes, the rash can begin to spread down. In severe cases, you get encephalitis, okay? Encephalitis is actually inflammation of the central nervous system. Meningitis is inflammation of / infection of the meninges. Encephalitis means that something has been able to get through the meninges and is now causing direct swelling of the brain and spinal column. Keep in mind, your skull is a fixed volume. Inflammation means that there's going to be increased fluid in a given area. Increased fluid in your skull means that something's going to have to give. Your skull's not going to expand. Your skull's not going to swell. So if more fluid's going in, means the brain is going to have to give up some of its space, and it's going to be squished. The squishing of the brain because of the fluid increase will result in brain damage. The measles can progress to what is referred to as subacute sclerosing panencephalitis. Okay, this is a neurological issue. Okay, you're going to get neurodegradation. Here, the central nervous system starts to break down. 1 in 1,000 children. Okay, so not only did you have the 6 million people a year dying, but of the survivors, 1 in 1,000 would get this subacute sclerosing panencephalitis. The virus gets in, damages cells, and spreads. The damaging of the cells results in increased inflammatory response. Also, because the viruses get in, they can't get out, messes with cellular metabolism, causes fusion of neighboring neurons. So cells die or cells fuse together, become one large, one large cell, which will ultimately die, destroying neural pathways. This subacute sclerosing panencephalitis will result in intellectual impairment. Okay. Either there's going to be loss of function, or there's going to be a retardation of mental development. Retardation of mental development could lead to also impairment of physical development. Pathogenesis here, highly pathogenic. There's going to be damage. Okay, the virus can spread from the skin to the mucosa. Okay, so it starts off on the skin, spreads to the mouth, the sinuses, the eyes, the mucus lining of the mouth, the sinuses, the eyes, and then descends nasopharynx, the throat, down into the lower respiratory system. There are no specific virulence factors, okay? Viruses get in, viruses get out. As they get out, they kill the cell. If they can't get out, what we see is, especially in the brain, syncytia being formed. Okay, remember syncytia. This is when multiple neighboring cells fuse into one large giant cell with multiple nuclei, which can't regulate itself and will ultimately die, leaving a large gap, a large open area. Transmission is respiratory droplets. Okay, it's not just coughs and sneezes. It turns out every time you breathe out, you are breathing out micro droplets of water, respiratory secretions. In those micro droplets, and it turns out it's the micro droplets we have to worry about the most. Whether, whatever respiratory disease we're talking about, the micro droplets stay in the air longer. The larger droplets from a cough, a sneeze, gravity affects them earlier and they fall within minutes. The micro droplets stay out there. They hang in the air 5, 10, 15 minutes. This is a person-to-person thing, okay? You're not going to see any animal in between. There's no vectors. It's person-to-person. I breathe out, you breathe in. Diagnosis is going to be clinical presentation. Where's the rash? What's the rash look like? What are the other symptoms they're showing? What they can look for is they can test for antibodies. If the infection's gone on long enough, you will see the beginning of the presentation of an antibody response. Depending on person to person, it varies. Also depending on what microbe, you're looking at anywhere from 7 to 14 days. You have, post-infection. Best prevention is the MR vaccine. Start it off early, get the boosters. Treatment, well, there's really no treatment. There's no magic bullet as an antiviral. So what you're going to see is, when you look at this list of treatments, reduce fever, suppress cough, replace fluids, relieve neurological and respiratory symptoms, blah, blah, blah. This is palpitative, okay? Keep the fluids going in, keep the patient somewhat comfortable. Let the disease run its course and let the immune system kick in and remove it.